Let the record show that we have a quorum present. I'm calling the committee to order. And I want to invite in Ms. Jennifer Ahorn as the witness today, and we're dealing with the Auditor General's update on recommendations as it relates to the Ministry of Health, Environment, Culture and Housing.
I swear by Almighty God that the evidence I shall give to this honorable Legislative Assembly shall be the truth, the whole truth, and nothing but the truth.
Good morning, Ms. Ahorn, and thanks for, I know you have a busy schedule, so we always appreciate when chief officers can find the time to attend the PAC meeting. As you will have been made aware, what we're dealing with today is the Auditor General's follow-up report on implementation of the recommendations made by the PAC and the Audit Office as relates to your ministry. And you would have seen the government minute, which was in response to some of these tabled in June 2018. One of the concerns we had at that time, and is still outstanding, is we need an update on the National Health Plan. I think the commitment was given that we would try and have the review done by the 31st of December 2018, and then we would move to an implementation plan. So we'd just like to know where are we with the National Health?
Thank you, Mr. Chair, and good morning to the members of the committee. Thank you for the opportunity to come and clarify any of the questions that the committee might have regarding the work that the ministry has been doing. In regards to the National Health Policy and Plan, we had hoped, as indicated in the government minute, that we would have completed the review and update of that plan by December of last year. However, the status of that is that we have deferred that to be dealt with later this year in collaboration with the Pan American Health Organization. The reason for that, there were several reasons behind it. We had some other work items that we needed to deal with. And also we are in the process of getting on board some additional staff at the ministry in the area of health. And I wanted to have those recruitments completed so that those members of the team would be part of that process once they're on board. So we are planning to start that review later this year. I will say, though, Mr. Chair, that the policy still remains a live document for the ministry. The vision within the policy is still something that everybody's working very hard to reach, which is the health and well-being for all in the Cayman Islands. And we're keeping those strategic directions and objectives in mind as we're working with the other areas as well.
Oh, and I need to remind you that you need to give us your full name and your position when you answer. We can do it. Okay. During that 6 months period, as you will be aware, we have had some concerns about the Health Services Authority. Has there been any policies sent down from the ministry in keeping with the vision and the plan to the HSA board to get them to address some of the concerns that we have had here as the PAC with the Health Services Authority?
And for the record, I'm Jennifer Ahorn. I'm the Chief Officer in the Ministry of Health, Environment, Culture and Housing. Mr. Chairman, I guess I would just like some, the concerns that you mentioned that the Public Accounts Committee had with the HSA, is that in regards to their finances, or?
Largely so, but also in regard to their quality issues, the monitoring of quality of healthcare, the assurances, the matrix by which they are determining that their quality of healthcare that they are given to the public is of a accepted standard.
No, thank you for that. The issue of matrices and reporting and the quality of care is something that we see as a really key piece of work that will come out of the work to update the National Health Policy and Plan. At the moment, a lot of those indices or data are done more or less on an ad hoc basis. They are monitored. The hospital does report to the board and up to the ministry through the board on things like hospital-acquired infection rates, the near misses, and those sorts of things. We also receive updates from the hospital regarding the matrices or the results coming out of the K-Health program, which is the primary care program for the indigent population. And we are seeing that their health outcomes are improving. We're seeing that there's a higher level of controlled hypertension and diabetes as opposed to what was in place prior to the K-Health. So those things are happening. We are getting that, but it's certainly an area that we need to strengthen, and it's something that we need to also look at what we need to put in place to get that kind of information on a more regular basis from all of the healthcare providers. And I do see that as a key piece of work that will come out of the update of the health policy.
Can you tell us whether any of those measurement of those indices involve peer review or medical audit? Not that I would expect you to get report on individual cases, but how are they, what methodology are they using to demonstrate that their care for hypertensive patients, diabetics, is improving?
Thank you, Mr. Chair. I'm not familiar with the methodology and the peer review that they're doing at the hospital. What we receive are the updates in terms of the data showing the percentage of patients who have controlled hypertension or who have the HbA1c, which is the measurement of controlled diabetes, and those numbers. But I'm not familiar with their processes behind the scenes.
You mentioned that you're expecting to get some involvement or assistance from the Pan American Health Organization. What form is that going to be? Consultative or secondment of staff, or?
The Pan American Health Organization has provided and continues to provide us with excellent technical support. So, for example, when we did the original National Health Policy and Plan, they provided us with a consultant who came and facilitated the process and assisted with the writing up of the policy itself. That's the kind of technical support we're anticipating with the review. We have had some discussions with the Pan American Health Organization already in terms of some of the assessment of our achievements against the policy that would form the baseline that we would move forward on. And again, that's the sort of assistance we're anticipating from them.
If we could move on to recommendation 2 in the government minute. Where are we with the other legislators' review, the health practice law, pharmacy law, and the public health law?
Okay, thank you, Mr. Chair. The public health law review is ongoing. We convened a review committee in 2018 that included representatives from the relevant government departments as well as some representatives from the private sector. We're hoping to present the recommendations from that committee to Cabinet in the coming month or so, and hopefully get approval for drafting instructions to be issued to start the process of actually drafting it. The public health law is a very large, broad law, and it hasn't been updated for some time. So we're expecting that the actual drafting process might take some time. But once we have the draft, we'll be looking to come out for public consultation, likely later in the calendar year. The pharmacy law, we have a draft bill for the pharmacy law that we are hoping to present to Cabinet sometime in the next month or two. And that would be for getting Cabinet's approval to bring the law out for public consultation. We've been working closely with the Pharmacy Council over the last several years to get the draft bill prepared, and so we are looking forward to getting the opportunity to come to the public and get the feedback from the broader stakeholders as well as the general public on that. The health practice law amendments are something that I am identified for later this year to be done. We had started to look at it. We've been getting feedback from the various councils on sort of a continual basis, and we compiled that. But we've decided that given that we want to look at the information, the data collection that I mentioned earlier, we thought we would wait until we've done that exercise to see whether we need to put things in the health practice law to compel the facilities and or the practitioners to provide the data that we're going to start looking for once we get that framework together and proposed. But it is something that we are going to be looking at later this year.
Wouldn't it be better to put the reporting requirements in the public health law? Isn't that where most of the disease reporting requirements are now?
Yes, the communicable disease reporting requirements are in the public health law. And they are looking, one of the recommendations with the public health law is to update and amend some of the requirements in terms of what is a reportable communicable disease. The justification or the thought behind looking at whether to put the reporting requirement for the statistics and the health information with the health practice law is to tie it in with the health practice facility certificate, so that it would be a requirement or a condition of their certificate.
The facility certificate or the individual professional certificate?
Would probably be, and again, this is just very preliminary, we haven't had a detailed discussion, but I think it would probably be tied to the facility certificate, so that the facilities where the practitioners are practicing would be reporting up on the data for that facility.
Okay, in recommendation 4, have you gotten any staff recruitment in place to improve the capacity to monitor the health systems and stuff like that, or?
Thank you, Mr. Chair. We have been able to get some additional funding in the most recent budget process to have an extra or additional policy officer at the Ministry of Health, which we're in the process of finalizing the job description through the portfolio of the Civil Service. The Department of Health Regulatory Services, which monitors the practitioners, the healthcare facilities, and the Health Insurance Commission, has an additional administrative secretary post that they're in the process of recruiting for. And there was also an additional health insurance inspector post that was approved in the budget, which they're currently in the process of recruiting for as well. So there is some ongoing recruitment now that will enhance the capacity. We've been very fortunate that because the financial situation has improved quite recently, that we're now able to get some of the extra resources that we need.
This has been an ongoing question for years. And it came up again yesterday when we were dealing with the NAU. Has any consideration been given to removing the requirement for indigent certification to be signed off by the minister as opposed to the admin staff?
Mr. Chair, I actually had a discussion with the Chief Officer for Community Affairs just last week around their work with the poor relief law and the need to look at that process. And I know that it's something that they're actively looking at, how they might better manage that, because they've identified that as an issue that they need to address as well. And we're standing by to support them in that.
My problem is that we've been looking a long time.
Yeah.
Recommendation 8, where the government would evaluate and design a performance of K-Health program as appropriate to extend it to cover the wider population. Can we have an update on what has transpired since July with that program?
Thank you, Mr. Chair. I've been advised by the CEO of the Health Services Authority that the discussions that they were having with the Civil Service Association actually had been put on hold pending the outcome of the discussions around whether or not the health insurance for the civil servants was going to change. You may recall that there was some discussion that the government may move to asking civil servants to contribute towards their health insurance premiums with the proviso that it would be opened up to the private sector as well. Obviously, that question needed to be answered, I think, before we were able to move forward. They decided between them, CISCA and the HSA, that they would sort of park the discussions about expanding the K-Health to the civil service until that had been resolved. I've been advised by the CEO that now that that has been resolved, they are planning to resume those discussions and look at rolling out the K-Health program to the civil service through the Civil Service Association discussions. And I think that the K-Health program is based on preventative and primary care and aligning the patient with a primary care physician who's charged with monitoring that patient and looking at their health outcomes. And I think that moving towards that model is a really great idea, because we've seen with the indigent population the improved health outcomes for those patients who are chronically ill. And to expand that across a broader patient pool has to be a benefit.
Just on a broader general position, how does the ministry action the commitments given by the government in a government minute? Is it through a policy directive or to the agencies such as the HSE?
Mr. Chair, it depends on the nature of the recommendation or the undertaking in the minute. And I suppose that it would also, so if, for example, there was something that we had agreed that an agency would undertake, and then we discover that they're no longer undertaking it or they haven't embarked on it, then that would be when if there hasn't already been a formal directive might be issued. But it will, so the issue with the legislative review, that's something that we're doing at the ministry level in consultation with Cabinet and our minister in terms of identifying the timelines and the priorities and so on.
But does not the HSA legislation itself require policy directives from the ministry in order for the HSA board to action policy decisions by the ministry? And is not also what the Public Authorities Law envisions in terms of communication between a ministry and a board? Mr. Chair,
I don't have either the Health Services Law or the Public Authorities Law in front of me,
okay.
but they both do provide for directives to be issued. And the Health Services Authority Law says that the minister may issue directives to the board, provided it's not something that's already in front of the board. And I think the Public Authorities Law language is likely similar. So I think that the law creates the opportunity, should the minister or ministry feel that a directive under the law is required, to issue that directive.
So the normal process would be the fact that you as chief officer sit on the board. That would be the normal process of communication as opposed to a formal directive.
Mr. Chair, that's correct.
Okay. The Minister of Education put some funds aside, $500,000 for scholarships, medical to fund scholarships for Cayman doctors to pursue postgraduate studies at board level certification. Can you give us an update on how many doctors have been sent off for board certification training and where they are and what specialties they're doing?
Mr. Chair, I don't have the scholarship process is still in process. The Ministry of Education, I don't think, have finished the review and award of the scholarships for that as yet. My understanding is that they're making a decision fairly soon. and that they've already had the interviews with the applicants and are currently reviewing them. I'm not sure what the areas of specialization are. The Health Services Authority has been working with the Ministry of Education on the scholarships and advising them on the basis of where they believe that the areas are that we need to enhance in terms of local specialists. So I can ask the Ministry of Education for more information in terms of the number of applicants and the number of awards, but I believe that the intention is to award 4 or 5 scholarships. I think it's 4, because I believe that the average value of the scholarship is $125,000 per year per student, and there's $500,000, as you said, in the budget. But I can ask the Ministry of Education for the details.
That would be appreciated. To Mr. Jefferson. Mr. Jefferson, if none of these scholarships on this $500,000 was awarded during the financial year 2018, that money has lapsed.
Thank you, Mr. Chairman. Yes, sir.
Do you know, because as I recall, this was a one-off thing. It wasn't a situation where education was committing to put $500,000 to this purpose on an annual basis.
Thank you, Mr. Chairman. Mr. Chairman, it would be relatively easy for the Ministry of Education to make a request that those funds occur again in the 2019 budget. It would either be through a request to Cabinet under Section 11.5 of the Public Management and Finance Law, or coming to Finance Committee under Section 12, one of those two routes, but the ability to do so in 19 exists.
I know what it says here, but I don't. It says here that some members are suggesting that the $500,000 is a per annum allocation. That is not my recollection, because I was basically the person who advocated and fought for this in Finance Committee. I was of the view that it was a one-off thing, and I know that there were people lined up to get scholarships who had been trying to get it, some of them 10 years. And I can't begin to express my disappointment that the whole year has gone by and no scholarship was granted.
Yes. Mr. Chairman, thank you, sir. I'm looking at the appropriation law, which obviously covers 18 and 19 financial years. What is described under the Ministry of Education, what is described as transfer payment 83, TP 83. The appropriation name is scholarships-medical. There is $500,000 appropriated to the 18 financial year, and also $500,000 already appropriated for the 19 financial year. So if the 18 financial years $500,000 has not been used, and there was a desire, there was a need to increase the 500,000 that's already been approved for 19, that could be pursued.
Okay, but that would take some time and come back to finance. One other, okay, thank you. The other question is, can you tell us what the HSA has been doing? Have they been, during this year, have they continued to provide specialist care at the hospital through locums?
Mr. Chair, my understanding is that they have some specialists on staff, but that other areas they do bring in locums.
Has the ministry reached out to countries like Canada or to UWI, which we have, I think it's 2. Annually, we get 2 positions in the medical program for the MBBS. Has the ministry reached out to try and get some similar thing for postgraduate studies through University of the West Indies?
Mr. Chair, there is a family medicine specialist training program that the Ministry and the Health Services Authority have through UE, or in collaboration with UE. I don't have the numbers with me, but I can get them in terms of the number of doctors who have taken up that training opportunity to get that specialist designation locally. In terms of reaching out to other jurisdictions and other countries, I know that the medical director and the chief medical officer, the acting chief medical officer, do liaise with their colleagues through the region and look at things like the internship posts that we have, and have facilitated some of our doctors doing their internships in other locations when we host their doctors here. But if you'd like, I can get the information for the committee regarding the number of doctors who are pursuing that family medicine.
But that's not, is that a board certification or is that a certificate program?
I would need to check.
Okay. But what I'm thinking about is I'm aware that several Caribbean countries have arrangements with the Canadian government, for instance, where the Canadian government gives certain concessions for specialist training to board certification. Is the ministry involved in any discussions around that sort of stuff?
Not at this time, but I think that's an opportunity we would have to look into pursuing.
Well, I also happen to be aware that Dr. Panton has been trying for some time to establish that kind of relationship. And I am not aware that he has been making any progress for that time, because he is he does have full professor status at I think it's the University of Vancouver, British Columbia, right?
UBC. Okay.
And the last time I had a conversation with him, he expressed disappointment that his overtures had either been ignored or completely rebuffed. And I think that that's unfortunate for many Caymanians who could avail themselves to that kind of training. So I would invite you to inquire into that.
And I will. Thank you, Mr. Chair.
Mr. Chairman, if I could supplement your comment with regards to the University of British Columbia, Vancouver. Certainly the chairman, through you, Mr. Chairman, is absolutely correct. We have notable Caymanians, Dr. Neely Panton, linked to the University of British Columbia in Vancouver, where I've been party to conversations in which they have demonstrated a willingness to assist the continuing education and human capital development of Caymanian doctors. So it seems in this instance, if we have one university willing to provide the assistance, it seems we should make this a priority in the first instance. To the chairman's comment, however, perhaps the University of British Columbia might seem too far away. We can look a bit closer to home. The University of the West Indies also, according to my information, has a Doctors of Medicine program in which they offer a number of specialist training opportunities where doctors can in fact specialize. We at one time, I think maybe even still do, have a relationship with the University of the West Indies at UCCI. So these are opportunities that are, as the chairman pointed out, readily available to us. All we need to do is reach back, and perhaps we might make this a bit of a priority. Thank you, Mr. Chairman.
And the other thing I'd like to add is I would ask you as chief officer to make a specific report to this committee why it has taken a year and no Caymanian has been awarded a scholarship under this program.
Mr. Chair, I will liaise with the Ministry of Education and ask for their assistance in that. The scholarship is under their ministry, and I'm not familiar with the process that's gone into getting to the point that we have reached, but I will liaise with them and work with them to get a report to this committee on that. With regards to the training opportunities at UE in particular, I would imagine that many of our doctors who are looking to avail themselves of this scholarship are hopefully looking at UE as one of the places that they are going to go and get some training at. Again, I don't have the details in terms of the areas that they're looking to get training in or where they're hoping to get the support to go and study, but I would hope that UE, who is, as you've mentioned, they're an established partner that we've had for some time, and we do have the family medicine training program with UE already through the HSA, so I would hope that UE is one of the partners that they're looking at with these scholarships.
Mr. Chairman, if I may,
I'm finished.
in the same vein, obviously these questions relate to recommendation number 11, which consisted of one of two additional recommendations that the Public Accounts Committee added to the previous 9 recommendations put forward by the Office of the Auditor General. We talked momentarily about the amount of annual funding that is available for residency training programs, and I believe the Honourable Financial Secretary stated the sum was in $500,000 per annum. My question specifically to the Chief Officer is, do we know how much funding per annum is made available per student in these residency training programs?
Through you, Mr. Chair, the $500,000 that the Financial Secretary spoke to, the TP 83, is for scholarships for residency training overseas. And my understanding is that the maximum grant is $125,000 per year. And that the scholarship, I believe, is intended to be over the life of the residency. And I understand, depending on the specialization that the doctor is pursuing, the residency, the specialist training program can take anywhere from 3 years to 7 years.
Thank you for that, Madam CEO. Through you, Mr. Chairman. The follow-up question is the maximum duration of the funding, and if I understand you correctly, $125,000 is available per year for the maximum duration of that specialist training, which can be, and as you're quite correct, range from 3 to 7 years. So that's a commitment that we're making to fund up to $125,000 per year for up to as much as 7 years. Is that accurate?
Mr. Chair, through you, I actually have a press release that the Ministry of Education sent out about the scholarship. The date of it is the 29th of October 2018. I was given this, and I'm assuming it's the final one that went out, but it says that it's a 5-year scholarship, and it will allow them to pursue studies at an institution recognized to provide high-level training in the specialty being pursued. The applicants will be required to return to the Cayman Islands, and it's valued at to work at the Health Services Authority for at least the length of time of the scholarship, and it's valued at a maximum of $125,000 per annum to cover tuition, other school-related fees and expenses, and a monthly stipend for living expenses. So that's the information that the Ministry of Education has put out.
Thank you for that testimony. Mr. Chairman, through you, first of all, I should have begun by, as the Chairman did, thanking you for your attendance, certainly taking time out of your busy schedule to inform this committee on what updates have been completed. I think in the benefit of the listening audience tuned in, when we look at the context of today's hearings, there were 11 recommendations, 9 by the Auditor General's Office, plus an additional 2 from the Public Accounts Committee. Of that total 11 recommendations, according to the information we've received, 2 have been implemented, 8 have been noted as some progress being made, and 1, there's been no progress at all. Looking at the 8 where some progress has been noted, 7 out of the 8 recommendations are tied to the National Health Policy and Strategic Plan. Earlier on, you spoke about determining timelines and priorities, and forgive me if I'm going over territory that the Chairman ably asked in his summary. But given that 7 out of the 8 recommendations have some link or dependency on the development and completion of a national health plan and policy. Can you inform this committee what is the timeline for completion of that national NHPP as to ensure that the 8 recommendations which are in progress can in fact be completed and implemented within a reasonable time frame?
Through you, Mr. Chair, thank you for the question. And as I mentioned earlier, it is not that the ministry believes that or feels that the health policy is not important. It's a policy document that is a guiding framework for the work that we do in the area of health at the ministry level. And while the policy was drafted to cover the time period up to 2017, we continue to work towards the various strategic objectives and the vision of the policy. So, for example, one of the objectives looked at enhancing human capital to ensure an available, competent, responsive, and productive health workforce to improve health outcomes. That was the third objective in the policy. And the scholarship that we've just been talking about, that the Ministry of Education is taking forward at the recommendation of the chairman, is one of the pieces of work that's working towards meeting that objective. Things like the legislation that we've been working on, the pharmacy legislation that we're hoping to have out for public consultation in the coming months, looks at improving the framework, the legislative governing framework for the healthcare system within the Cayman Islands. Some of the things that are being proposed in that pharmacy legislation, for example, are to do with looking at product safety, at looking at where we're getting our pharmaceuticals from, looking at things like requiring that there be a designated pharmacy manager at each of the pharmacies who is a qualified pharmacist and is the responsible individual for making sure that the patient safety things are being implemented. Some of the other things that we've been doing that are still working towards this policy are things like the One Health conference that Public Health has done, which is looking at the overlap between health services, agriculture, and the other sectors. And they've had the conference for 2 years now, and I'm sure they'll have it again this year, and they've done it in consultation or collaboration with the Pan American Health Organization, who have told us that it's one of the first of its kind in the region, and it's bringing together all of the stakeholders that have a role to play in ensuring the public's health and well-being. So I say all of that to say that the policy, we do want to get to updating it this year. We are, as I mentioned earlier, we are in the process of recruiting some staff at the ministry to work in the area of health, and I would like to have them on board for that process, and I'm hoping to have them on board in the coming months. And we have already started the discussions with the Pan American Health Organization regarding the assistance that they're going to provide us in reviewing and updating the policy. I do think that the vision that is embodied in the policy is one that is still very relevant today, and one that everyone hopefully is aspiring to, which is health and well-being for everyone in the Cayman Islands. And we are continuing to try to work towards that.
Thank you for that response. I believe I only have one more question, but it refers to the recommendation, specifically recommendation number 9, contained on page 14 of the follow-up on past PAC recommendations report, which has been identified as, of the 11 recommendations, the only one where no progress has been made at all. Recommendation number 9 stated for the record, Mr. Chairman, through you, that the government should ensure that health statistics used for purposes of planning, management, and accountability distinguish between Caymanian and non-Caymanian populations. Whilst the response that you provided us back in July of last year was, in my estimation, admirable, that healthcare does not discriminate, it provides services for all of the residents, and it does not distinguish between Caymanian and non-Caymanian. I have a two-part question. The first is, the Cayman Islands, of those two population demographics, Caymanian and non-Caymanian, one is a dominant population, the other is a transient population. And as such, would you agree that there are some medical conditions that may be considered imported versus other medical conditions that may be considered homegrown. And this is perhaps what the Office of the Auditor General referred to when they took the view that the collection of these demographics are important for the purposes of planning. First question.
Okay, Mr. Chair, through you, I would agree that and we do agree that there are going to be some diseases or some things that are more likely to be imported versus homegrown. A lot of the things that are costing the healthcare system in terms of care are the chronic non-communicable diseases, which are the lifestyle diseases, the obesity, the cancer, the smoking, the mental health. And those are the ones that can also be prevented. And the focus needs to be on the prevention of those diseases throughout the population within the Cayman Islands. Having the information on a Caymanian versus non-Caymanian, and the position of the ministry isn't that it wouldn't be useful necessarily. The position that, as you mentioned, the comment was really getting to that the expectation is that the health system needs to provide care for everyone who is here and meet them here and provide that care. Some of the sort of imported diseases are some of the possibly communicable ones. So tuberculosis is an example of something that quite often we'll see, or if people have traveled. There's a recent advisory that we issued regarding dengue fever, which if you've traveled to some of the areas in the region where it's actually quite prevalent right now, just to be extra vigilant about the symptoms if you experience them. So, but I think, we need to, and I mentioned earlier, one of the areas that we really need to focus on is the information system that we have in terms of the population's health, and make sure that we've identified and put in place a mechanism to get that data and to be able to use that to better inform some of the decisions and the priorities that we have for the health system and the work of the ministry. So I'm hoping that when we get to that point, that there will be a way to capture the data and as distinguished between Caymanian and non-Caymanian, looking at the different, particularly the big areas around the CNCDs, the chronic non-communicable diseases, and looking at how we can better prevent those and manage them.
Thank you for that response, and I'm encouraged by that response in that it is your testimony today that you believe those demographic distinctions would be, to use your words, useful to the HSA. It is interesting, however, that today that information is useful when in June 2018, the government response to the same question was also on page 14, recommendation number 9, and I quote, "The government notes the recommendation and would add that expectation is that the healthcare system would address the needs of all residents, Caymanians or non-Caymanian, but the immigration status of the individual does not matter." So on the one hand, the information is either useful today or a year ago, doesn't matter. That leads me to my second part of the question. To the Office of the Auditor General's point, if I understand correctly where they're going with this, and I certainly have the benefit of the Office of the Auditor General present so they can correct me if I'm going astray. But these demographic statistics can be used and are used in hospitals across the globe, or healthcare systems across the globe, to predict the types of service demands on the HSA in the future. And this information may prove useful to hospital administrations come budget time when they are seeking to justify their expenditure requirements for the year, or in this case, the 2 years ahead. So again, from a planning perspective, not only is it useful, but it is the viewpoint of this committee and that of the Auditor General's committee that it is necessary in terms of good governance, that it should be implemented. Furthermore, you mentioned amendments to the changes to the pharmacy law, where I believe statistical analysis is also missing and useful. in making sure the right amount of pharmaceuticals are available to the HSA pharmacy from time to time. Now, if I may interject a personal experience, many of us have aging parents. I certainly have an aging mother. I have lost track of the amount of times my mother has expressed disappointment that the pharmaceutical she is prescribed by her resident doctor is not available to her at the hospital, at the HSA. And again, this in my mind comes back to a lack of usable information that will guide administration policy. I wonder if you can speak to that, Madam CEO.
Okay. Thank you, Mr. Chair, through you. Just to pick up on the member's first point about the previous comment that it doesn't matter versus it being useful. I think that the comment about the immigration status of the individual not mattering wasn't to say, it was to get to what you mentioned earlier, which was to recognize that regardless of whether the individual is Caymanian or non-Caymanian, we believe that the health system needs to meet the needs of our resident population. So that, just to say that it's not necessarily a change in the position, per se. Regarding the need for data to better inform us, and you mentioned the pharmacy law and the impact that it might have, and that from a planning perspective, the Caymanian versus non-Caymanian data would be useful for informing things like budget requests and so on. So the Health Services Authority, in looking at their budget requests and their requests for the subsidies that they get and so on, they're looking at the services that they're being asked to provide to their population, the patients that are coming through. And they're also looking at things like, we had a recommendation, I can't remember which year it was, that the Health Services Authority came and said to us, look, we're having a lot more patients with chronic non-communicable diseases who are exhausting their insurance benefits, particularly in the area of pharmaceuticals. We would recommend that government look at subsidizing their care. So we have an output now at the ministry that we subsidize. It's it's a chronic non-communicable disease output, and I can't remember the exact title, but that was a recommendation that the HSA came forward with in a budget process based on what they had been seeing with the patients that had been coming, the demands that they had been seeing. We have a similar output for the over 60 who are or underinsured, to look at making sure that they're able to access care that they need, and there's a means, Patient Financial Services, the HSA, works with the patients to see what their ability to pay is, and when they determine that they don't have, they only can meet some of the costs, then the rest of it is picked up by the government. So the Health Services Authority does actively look at those sorts of things when they're putting together their budget requests. In terms of the pharmacy law and the impact that it might have on the HSA's ability to keep some of these pharmaceuticals in stock, one of the programs that we already have in place through is the INCB, the International Narcotics Board reporting requirements, that the National Drug Council acts as the focal point in terms of gathering the information from not just the HSA, but all of the pharmacies on the island in terms of their needs for importation of narcotics and the use of narcotics. And we're required to report that up to the global body and to get quotas each year based on our requests, because it's quite tightly governed on a global basis. And I think one of my understanding is that because we have such an established, for example, hospice care here, the Cayman Islands is quite a big consumer of morphine compared to other jurisdictions of a similar size or globally. So there's a process there for that. And I'm aware that sometimes some of the shortages, particularly in the areas of narcotics, might be due to a lag between we've requested a quota, we've exhausted our quota, we need an increased quota, and we get that. I also know that in the past, the HSA has had some issues in terms of procuring some drugs that we've seen some shortages globally. I think the ADHD drugs were an example of that a few years ago, where everybody was having trouble accessing them. My understanding is that the HSA has looked at and has tightened up some of their pharmacy management and procurement to try and stay on top of those things and ahead of the curve when it comes to those matters.
Thank you for that question. Just on the basis, through you, Mr. Chairman, in your testimony, Madam Chief Officer, whilst recognizing the challenges related to the acquisition of narcotics and otherwise serious drugs that carry side effects, my representation included much more benign medications such as blood pressure medication. Those things being out of stock, and surely the reasonings for acquiring a restricted narcotic and blood pressure management medication are separate matters, but the consistent note is that both find themselves regularly out of stock. And again, perhaps it's a planning matter. You can answer that if you wish. But I just have one final question, Madam Chief Officer, and that is, in the response to recommendation number 9, contained on page 14, it is stated, and I quote, "We understand from discussion with the ministry that they are still considering whether and how it might implement this recommendation of the gathering of health statistics by demographic." If I may be so bold as to make a suggestion, we are changing medical forms, application forms almost all the time. If we include the single line demographic question, are you Caymanian, Caymanian status, permanent residence, work permit holder, or a minor or dependent, one line will be able to allow us to create that categorization or stratification, which, if I may mention, another but connected report from the Auditor General's Office, and that is the workforce management of the Cayman Islands, where yesterday we heard encouragingly that the Minister of Community Affairs, but I've seen it take place across government administrations, that our collection of data is being collected more prudently and effectively, as the Auditor General's Office recommended, so that we can analyze this information so that it can produce, through automation, responses that will improve efficiencies. What may take a person 3 hours, a computer will take 5 seconds to do, and it's predictive. These are information, a computer system. Once we have established those categories, then that computer system can categorize the number of patients per incident and their demographic information, which would thereafter be useful, I would imagine, in informing the hospital administration from whence these diagnoses and treatments are coming from, and thereby strengthen our future planning. But again, just a suggestion, one way how this recommendation may be easily recommended by a line item on a form and better use of computer technology. Thank you, Mr. Chairman.
I had just 2 follow-up questions. No, he said he was finished, right? Yeah. You mentioned that the new pharmacy law is going to specify sources of pharmaceuticals in order to establish standards. Some of those exist now. How is that the existing requirement of the pharmacy law being enforced?
Sorry, Mr. Chair, how is the requirement in terms of this?
As I recall, there are certain restrictions of where pharmaceuticals can be imported from now. I think a kind of a broad caveat is it has to either have American, US, Canadian, or British formulary approval, right? The question I'm asking is, how is that being enforced now? And if you're aware of any incidences where stuff may be imported from areas that are not included under those formularies.
Mr. Chair, in terms of the monitoring and enforcement of that, I would need to go and speak to the chief pharmacist to get some more information on that. I have heard anecdotally And this is one of the reasons, one of the many reasons for the need to update the pharmacy law. I have anecdotally heard of concerns from consumers regarding, for example, I picked up my prescription, I opened the box, and well, first of all, nothing was in English on the box, and then I opened it up, and the leaflet inside that tells me what I need to be careful of and how I'm supposed to take this and where I'm supposed to put it, there was no English on that either. And surely, that needs to be addressed. And so one of the provisions in the proposed pharmacy law is to do with what we're calling product licenses, which basically requires that if a product isn't already on one of the formularies, as you mentioned, that there would be an approval through the Pharmacy Council in order to be able to import it and sell it in the Cayman Islands. And there is a provision in the legislation that the packaging has to have English. That's another provision that is in the draft legislation as well. But if you like, I can get some...
I trust that sufficient safeguards are being built in to prevent the very corruptive nature of that process, knowing how pharmaceuticals are sold to doctors by salesmen.
So there are provisions regarding what doctors can dispense, and I think certainly when...
No, I'm talking specifically about getting certified by the Pharmacy Council.
Okay. Well, the provision is there for the council to certify.
I think it's an internationally known thing that in the pharmaceutical industry, more money is spent on lobbying than on research.
Mm-hmm. Yeah, agreed.
One other question. There was a policy in place for many, many years that people who were HIV positive were not given a work permit. Has that policy changed?
Mr. Chair, I would need to check with immigration on
Could you
that.
please and let us know?
My understanding through some of the discussions that we have had over the years with immigration is that was changing, that policy was changed, but I would need to check with immigration and report back.
One other question, or two other questions. Are you aware of any other country in the world that gives transient population equal say in the health systems that are provided, and that we address both, that addresses both equally?
Mr. Chair, in terms of an equal say, in terms of
in planning and what we provide and everything else.
I can only...
Because the stated policy of the government is that non-Caymanians have equal access and equal influence on government healthcare policy.
Is that, sorry, Mr. Chair, is that in regards to our response on the
Yes.
that Councillor Harris was asking about? The position wasn't so much in regards to their say in the system or their say in the process. It was more to recognize that the expectation is that we will provide the ability to access care for everyone who is here, so that if you are here as a work permit holder, that you shouldn't be prevented from accessing care in the system, and that you may need to have care for your diabetes or your hypertension, and that you once you're here, for example, someone might come on a work permit and become ill with cancer. That's a cancer case that's here in the Cayman Islands. Our position is not that the government of the Cayman Islands should pay for that person's care, but the position was that if this is a cancer that is here, what is our responsibility to have a system that facilitates access to that care, not necessarily locally, but in the case of cancer, most of the care now is overseas, with the exception of some, like the chemotherapy unit at the hospital. So it's not so much in terms of to say that a non-Caymanian should have an equal say in the care that is offered or the healthcare system here. It was to say that in terms of when we're looking at the care that's going to be required. We look at the population that is resident and requiring that care.
But certainly the policy should indicate that while the opportunity to access the health care is there, the methodology by which one actions that care is solely the responsibility of the individual or the employer, not of the government, equally as for Cayman.
And Mr. Chair, I agree, and that's one of the underpinnings of the health insurance legislation as well, that the expectation is that anyone who's legally resident is required to have that minimum level of health insurance coverage, and that they have a responsibility to maintain that as their contribution to their care. And so certainly that I agree that, you know, the individual needs to, it's not the government's responsibility to pay for everybody's care. The government's responsibility is to make sure that, you know, in terms of access to care, affordability of care, and the availability of care, those sorts of things. But the health insurance legislation is there in recognition of that very fact, that you can't expect to come here and have a free-for-all in terms of your access to care. You have a personal responsibility if you are here to make sure that you have that insurance and that you're contributing in that way.
Looking at the budget, the average markup on pharmaceuticals at the HSA is 100% plus. Has the ministry given any consideration to issuing a policy to reduce the cost of medications to our citizens by reducing the markup and or by removing the duty on pharmaceuticals and medical and surgical supplies?
Thank you, Mr. Chair. My understanding from the HSA is that they've actually fairly recently changed their markup on the pharmaceuticals, and I will get that information for you and share it with you, because I think they recognized that particularly for some of the more expensive pharmaceuticals, the 100% markup was putting it outside the realm of reason in terms of the cost of the pharmaceuticals. The question regarding taking off the import duty on pharmaceuticals, that's not a discussion that we're currently having. It's one that we have had in the past, but certainly something that I will take away and look at again.
Mr. Chairman, first of all, I want to thank the Chief Officer for coming down here and wish her a Happy New Year. I know she has a busy year ahead of her. And I also want to apologize to the Chief Officer. And the reason being, as my colleague from Prospect pointed out, the 8 of the 11 recommendations are driven by the creation of the National Health Policy. And I just want to read section 44.3 of the Constitution here, Mr. Chairman, if you don't mind, just a preamble, what my question is going to be. It says, the Cabinet shall have responsibility for the formulation of policy, including directing the implementation of such policy, insofar as it relates to every aspect of government except those matters for which the Governor has special responsibility under Section 55, and the Cabinet shall be collectively responsible to the Legislative Assembly for such policies and their implementations. The report of the Auditor General that we are discussing here today, a lot of it hinges on government policy. And unfortunately, the terms of reference of this committee does not allow us to question government policy. That is something that is reserved for the Legislative Assembly. Thus the reason I was actually more quiet today, for the simple fact that the issues that we're dealing with is structural, that has to be dealt with at a political level and has to be dealt with by ministers and members of the Legislative Assembly. So in essence, to have the Chief Officer here to defend actions that are driven by a policy that is reserved for the political directorate is a little bit unfortunate. And this is something that we'll have to deal with at the Legislative Assembly level. But we need to get the policy right. Yesterday, we have already, based on discussions that we had with the Ministry of Community Affairs, that the issues that we have on both the NAU and even on healthcare standpoint is a bigger issue. And at the end of the day, the civil service is tasked with carrying out or implementing the policy that the government has established. So what I say all of that to say, and coming back to this document, the main driving force has got to be going back to recommendation number 1, which deals with the health insurance policy. And just to bring it back home and to collapse what I'm saying, Mr. Chairman, it says the recommendation reads as follows. The government should update the national health policy and strategic plan for the Cayman Islands, including developing the operational plan necessary for its implementation and the monitoring and evaluation plan required to track progress and results. The original response was, as noted in the OAG report, the ministry is sometimes faced with having to deliver on changing policy priorities for the government of the day. However, the ministry will endeavor to complete this in the second half of 2017. So the plan implementation date was reviewed September 2017, operational plan March 2018. Then it came back again in June 2018, says review July to December 2018, operational plan to be TBC. And now we're hearing it's going to be something for this year. When you consider, Mr. Chairman, that the health practices law was recently updated as of 2017, the latest one, but then when you factor in that the public health law was last updated in 2002, and that the pharmacy law was last done in 1979, 40 years ago, the reality of it is that we have to get serious with regards to the policy, and then we can start looking at what is it that we're going to do with regards to implementation of the policy. But we need to get the policy right. And this is something that is outside, well, the policy discussion is outside the remit of this committee. So I say all of that to say, Mr. Chairman, and the only question I have for the Chief Officer is in terms of going back to the national health policy, which is recommendation number 1, when can we as members of the Legislative Assembly and members of this committee expect to have a concrete date when that national health policy will be completed? Because that is a driver for everything else. And it makes no use to go around and have all of these questions when there is no policy that really drives what it is that we need to get done. And that's the only question I have for this morning. Thank you.
Thank you, Mr. Chair, through you. The member is correct that the policy is there to drive to drive the work, and it is there to guide us. And as I mentioned earlier, the policy, although it covered, when it was drafted, it covered the time period from 2012 to 2017. And we haven't reviewed it and updated it. The policy is still there. It's still used as a guiding framework, and the work that we do is contributing towards that. The objectives that we have in the policy, there were 9 of them, and they were to do with, and I'm sure the member has seen the policy, but strengthening the institutional capacity for leadership and governance, implementing an equitable and sustainable health financing model, enhancing human capital, when I read earlier, promote the contribution to all sectors to health and well-being, achieve an educated and empowered health-conscious population, to further develop accessible, high-quality, integrated health service delivery networks based on the primary health care approach, to develop a robust health information system with multi-agency linkages, improving the quality and coverage of health-relevant information to be used for decision-making. We've spoken a lot about that this morning. Promote increased research for the production, dissemination, utilization of health-relevant information, knowledge, and scientific evidence for decision-making. And the final one, to maintain the capacity to respond to and manage all emergencies and disasters to mitigate the impact on health. So when we have those within the policy, and as I mentioned earlier, the overall vision of health and well-being for all in the Cayman Islands, while the policy was intended initially for 2012 to 2017, we believe that all of those objectives are still very relevant and very applicable today, and that the vision is still one that I believe is something that we can all agree would be a great outcome, to have the health and well-being for all in the Cayman Islands. And the review of that policy or that plan is something that, what I anticipate we'll see is it may change in terms of the prioritization. We may have some new objectives that are brought to bear in the discussions, but I think that largely a lot of the things that we have in place now will still obtain, or do still obtain. And all of the work that we've been doing at the ministry has been with those objectives and that vision in mind. So the timeline for the update of that policy to do that check, to see if the policy that we have is still as relevant as we think it is, that, as I mentioned earlier, is something that we're looking to work with Pan American Health Organization and do that review in the second half of this year. So in terms of the timelines for when the updated policy would be coming forward, I would say towards the end of this year.
Thank you, Mr. Aaron, for that response. I'm greatly appreciated. Just one supplementary then, based on your response. The OAG report calls for that once the policy has been updated, it then calls for an operational plan. The question is then, was there an operational plan completed for the policy that we had for the 2012 to 2017? And if so, can we at least, if there was one done, can we at least get a copy of it? Because I've not seen that operational plan. I think that maybe that would have been helpful to the committee and its members.
Okay. Through you, Mr. Chair, the operational plan was not completed. We started to do some work on that with the Pan American Health Organization shortly after the policy was approved, but that piece of work wasn't completed. So that's definitely something that we would make sure with the next, with the review, that the operational plan gets done, because that's a big gap that we have.
Okay. Mr. Chairman?
Yeah.
I have two questions. One is a reminder to the committee, and if I start with that, and the other has to do with the witness. Just a reminder to the committee, yesterday we asked a question relevant to indigent medical care and the distribution of it to the Ministry of Community Affairs, of which they could not answer because it was a remit of the Ministry of Health. Yesterday I was a bystander. I thought that was an important question, and I think the answer to it would be useful for the standpoint of the Ministry of Community Affairs. I was searching my notes to see if I could regurgitate the question. I could not find it, so I will remind or encourage members to maybe, if they're familiar with it, to ask it again. But my question to the Chief Officer is, there was, and again forgive me for not being able to quote the policy guidance, but there was a policy guidance recommendation as it relates to the indigent medical care, particularly the indigent overseas medical care costs. And the government sought to mitigate those expenditure by examining how much of those indigent healthcare incidents could be diverted to local providers, Health City or otherwise, versus going overseas in an attempt to reduce the, give or take, $30 million a year I think we're spending on overseas indigent medical care. Is the Chief Officer in a position to provide an update to this committee as to when or how much progress has been made in developing that policy directive, which again is to divert indigent medical care to local services versus sending them overseas? Thank you.
Through you, Mr. Chair, just the $30 million that the member is referring to, I believe, is what we call NGS 55, which is actually the Non-Health Services Authority care for the indigent, seafarers, and veterans. So it's not just the indigent population, but a big chunk of it is the indigent population. And it's also not all overseas. The policy in terms of accessing care is, if it's not for the indigent population and for the Cineco insured, including the seafarers and veterans, if the HSA is not able to provide the care, a request is made by the physician for a referral to go to an outside provider. Depending on, so I'll talk about Cineco because I'm not familiar with all of the private insurance companies' procedures, but I imagine that they're very similar. So when a referral is requested for care outside of the Health Services Authority, Cineco will do an assessment to determine where the patient can go. The referral can sometimes take physician-to-physician referral, which means that the doctor making the referral knows that this other doctor is the one they want the patient to go to because it's particularly complicated or specialized. There can be a general referral, just specifying the type of care that's needed. When Cineco receives the referral and it's been reviewed and deemed medically necessary by the chief medical officer, Cineco will then look at the care that's being requested and make a determination in terms of where the patient can go. And now Cineco is actually under the financial secretary, so he may be able to speak to it in more detail than I can. But in the criteria that Cineco will be looking at in determining where the care is being accessed is going to be availability and cost. If it's not a physician-to-physician referral, those are the factors that they're going to look at. So not every hospital provides every type of care. And so once they've determined who within, and Cineco has a provider network that they have negotiated, which includes the local providers as well as overseas providers. Once a determination has been made in terms of the availability of the care, and I believe the preference would be is to look at local providers first, the other factor that they're going to look at is the cost. So in the case where the local provider is cost effective and can provide the care, I believe that that's where Cineco will send the patient. So for NGS 55, for that non-HSA care, we're currently paying for that on a fee-for-service basis, which means that we're only paying for the care that is consumed, and we're paying Cineco an administrative services fee for access to their network of providers. So the idea is, or what should be happening, is that we're paying, with the exception of that fee that we pay Cineco, we're accessing the care that's required for the least cost that is available, whether it is a local or an overseas provider, because Cineco is performing that role as the gatekeeper for that care. So that's how that NGS 55 process works. So the care that is getting consumed, we should be paying the least amount for it through that process already. Some of the challenges we've had in the past with NGS 55, some years ago, we were able to get support for putting forward, and this predates Health City being on island. This is before we had any tertiary care available on island. We were able to get Cabinet to support putting in place what we called the Jamaica First policy for the indigent seafarers and veterans. We had some instances before that where one example we had was a patient needed some cardiac care. The hospital in Jamaica had confirmed they could provide it. The cost coming out of Jamaica was $17,000. The cost coming out of a South Florida hospital was $250,000. And in the past, what would happen sometimes is that the patient would say, well, I want to go to South Florida, and off they would go. So we were able to get support a few years ago for Cineco to put in place what we referred to as that Jamaica First policy, where if you can't be handled locally, the next stop for the indigent population would be to check with Jamaica and see if Jamaica can provide the care, and in the event that Jamaica can't provide the care, then they will go to a hospital further afield overseas. There were some examples in the area of cardiac care where I know Cineco had negotiated incredibly preferential rates with a hospital further north in the United States, and sometimes they were actually less expensive than Jamaica, so that sometimes Jamaica wasn't actually the least cost option in a very few instances, but Cineco would manage that. So that's a policy that was put in place and I believe is still in place to this day to try and mitigate that. And I think one of the things that we have to bear in mind, particularly with the cost of indigent care, is that the number of people in that group has continued to increase. And I know you spoke yesterday about the welfare system and the need to look at it from a holistic perspective. And the number of indigents in the last 5 or 10 years has gone from 1,200 to 1,700, or from 1,000 to 1,700 people. And what we're seeing as well is that half of those people are 60 and over, and that the majority of those people 60 and over, the vast majority of them are female that are on the indigent list. So, that's something that we need to look at, is that's a big chunk of that indigent population. And I had a conversation with the Chief Officer of Community Affairs and her deputy saying, in many ways we need to look at, there's indigents and then there's indigents. So you will have the working age indigents who may be temporarily indigent for a variety of reasons, whether it's a health reason or they're just between jobs. And then you'll have this group that, as I was saying, makes up half of the indigent population who are post-retirement age, are not likely to be out looking for work, and we need to start looking at whether we need to break that population up and look at more tailored programs for them. And I believe that that's something that the Ministry of Community Affairs is actively looking at doing from a more holistic perspective. So the thing that's been driving up the expenditure for NGS 55, and we have an output with the hospital, with the Health Services Authority called HEA2, which is the Health Services Authority care for the indigents. And, things that are seeing the increase in those two line items, it's being driven by just the numbers of people who are accessing the program. And the other thing we need to remember as well is that, we have seen over the years that being indigent doesn't necessarily mean that you're not healthy. We had a figure that Dr. Kumar used to talk about back when he was still here. You look at the indigent population, and 20% of that population are consuming 80% of that health care. So, we need to sort of get our arms around how we can better manage, that 20% and prevent them. And this was the underpinning of the K-Health program that we talked about earlier, was looking at how do we prevent this patient from ending up on dialysis? How do we prevent this patient from having a catastrophic cardiovascular event and needing an intervention? Well, we go back to the basics and we align them with a physician who's responsible for making sure that they're taking their medication if they're hypertensive, or they're monitoring their sugar if they're diabetic, they're getting nutritional counseling if the issue is diabetes or obesity, and those sorts of things. So, the indigent group it's an interesting mix of different types of needs, and something that as I said, I think Community Affairs is actively looking at some sort of holistic approach to their services.
Absolutely. Mr. Chairman, just a supplementary, with your permission. I thank you for pointing out that there are indigents and then there are indigents. I thank you for pointing out that whether of those categories, 20% of the population is consuming 80% of the services. This category is driving the increasing cost of NGS 55. Is there any consideration being made by the ministry to remove the choice option, as you stated before, Health City, Doctors Hospital, Miami-Dade, the patient? The common denominator in the indigent and indigents is that neither group has the wherewithal to pay for these needed services, and the expectation is that the government, who doesn't collect income taxes, has the obligation to pay for it. Is therefore any consideration being made on the same government who's being asked, if not obligated, to pay for these services, to remove the choice option? You can't pay for it as a patient, you acknowledge you need it, trust our doctors and medical staff to direct you the best possible choice, but we, the HSA, will decide where you're going, not you. First question. Second question on the referrals. Again, we all receive feedback from our constituents from time to time. There seems to be the status quo belief that there is a delay in issuing needed referrals away from the HSA to whether it be Health City or Doctors Hospital, when certainly the motivation in the administration of healthcare should be what is in the patient's best interest, not is what necessarily in the HSA's best interest, Health City's best interest, Doctors Hospital's best interest, competition, egos, etc. Can you speak to the perceived delays in the referral process that takes patients away from the services of the HSA to other local institutions? Two-part question, but if you can answer both, I'd appreciate it.
Okay, thank you, Mr. Chair. Through you. They're actually in some ways linked in terms of starting with the second part and the perceived delay in issuing needed referrals away from the HSA. Sometimes because some of these cases come to the ministry for intervention, and some of the ones that I've been made aware of are situations where, as you said, this is an indigent person who's not in a position to pay for their care, and that's why they're on the list that they are, where they're getting the care from the Health Services Authority. The Health Services Authority is able to continue to provide that care. The Chief Medical Officer has been, asked to look at, so they might, the patient, in one instance, the patient had said to their doctor, I want you to send me to another facility. And the doctor said, well, we can care for you here. We've been caring for you here. There's no reason for us to transfer you unless your situation changes. We're able to provide that care. And the patient was not satisfied with that response, and their family wasn't satisfied with that response. So it was elevated to the acting chief medical officer, who reviewed it and confirmed that, in their opinion, they agreed with the attending physician, who believed that the care that the patient was getting was appropriate to the patient's condition. It was meeting the patient's need, and the HSA was able to provide that care, and there was no reason to transfer them outside of the HSA. The patient and their family were still not satisfied with that response and wanted to be transferred out. In that particular situation, and you asked earlier about eliminating the choice option. That is where that choice option has been eliminated, and it already has been taken out of play. The example that I spoke about earlier, where it was Jamaica versus South Florida, that situation doesn't arise anymore because of the systems that have been put in place. The patient may still want to go to South Florida or somewhere further afield, but the choice option has already been largely eliminated. There are some exceptions, and usually, and I have seen these as well, where the HSA actually supports a patient being referred out to another facility if there is a need for a second opinion with another specialist, or if there's a particularly complicated medical issue that could potentially move into areas. Like, they do work very closely together, the different facilities, in terms of managing the patients and their transfers between them. The HSA, to my knowledge, if there's a referral, it's been made because the HSA can't provide that care. And it would not be in the HSA's best interest to retain that patient any longer than they should, because there would be, I would think, a liability associated with that. And I believe the HSA is very cognizant of that. If we have a patient at the HSA that we can't care for, we've got a referral in place, it's not in the HSA's interest to keep that. Some of the delay that comes up with referrals to other facilities is to do with things like the availability at the other facilities, the scheduling of appointments. Sometimes the insurance companies aren't always that quick off the draw in terms of actioning a referral, depending on their processes. So there's a lot of other things that go on behind. From the patient's perspective, it might appear, and you said it's a perception, that the HSA is dragging their feet or somebody's holding on to it and not letting them go. But there's a lot of different factors that come into play. But I have seen that, for example, the communications between the HSA and some of the other hospitals that they refer to, they're ongoing, they collaborate, they work very well together in terms of patients being moved out when we can't provide that care. So, and just backing up, and again, to your first question about eliminating that choice option with a view of saving money and making sure that we're getting the most cost-effective care. I mean, those procedures through that referral process are already in place. We do have some occasions where there are I guess, like I said, patient or physician-to-physician referrals, where the insurance company will have to look at that and make sure that it's not completely stratospherically out of whack in terms of what the other cost would be. But that choice option for the indigent population isn't there anymore.
Just a few follow-up. I'm a little concerned that I haven't heard quality of care mentioned and then this cost availability analysis, because the indigent should be entitled to the same quality care as a rich person, and I'm a little concerned of how that denial of choice is being enforced. Can you tell me where does quality come into this equation?
Thank you, Mr. Chair, and that is it's an omission on my part, not to mention that the quality of care is a key concern as well, and that part of the work that Cineco does in terms of their network of providers is to make sure that the quality of care that they're getting is the best that they can get in a cost-effective way. And that was just an omission from my response. The question was around cost savings in particular. But I agree that it's not a situation where because you're indigent, you're not entitled to good quality health care. That's not the case at all, and that's not the intention of the policy.
Okay. There used to be in place a situation where indigents or other people who may not have the immediate financial capacity to pay for overseas health care in particular, but they had assets in that the government would advance the money on the charge over the assets. Is that been completely discontinued?
Mr. Chair, those would be what we refer to as advanced patients, where they are underinsured and that the family signs like a surety to the government. And we would then fund their care out of NGS 55, the same line item that you're talking about for the indigents. And the family then is expected to go to the Ministry of Finance and the Debt Recovery Unit and set up a payment plan. And I don't know if the Accountant General can chime in and let us know the status of that, whether that's still an ongoing program that the Ministry of Finance is actively engaged in or not.
Mr. Chair, Matthew Tibbetts, Accountant General. That's correct. We still offer the medical loans for the population, correct?
And are you offering that on like a straight loan payment, or is there any kind of reverse mortgage applications where the person has an asset and is charged against the asset, knowing the indigent person or is not in a position to make payments, but the charge stays on the property, so that whoever inherits it, if they want to get the capital gains from it, would have to pay?
Mr. Chair, we try to work with the people as much as possible, and as we know they're vulnerable in this situation. We also are willing, in some cases, to take the second charge on a property, even if they're unable to offer the first charge. We try to work with people. We have cases where people are paying $35, $36 a month. So it's a very small payment in some cases for amounts that are, in some cases, $10,000 and so on. So we try to work with people as much as possible.
Okay. Well, the other question I have is two other questions. The one country in this region, other than the U.S., that has reputation for exceptional health care is Cuba. Is there any particular reason why Cuba is not put in this equation with Jamaica versus U.S.?
Mr. Chair, that would be something that we would need to look at. The countries that we have used in terms of overseas care in the past, it's been driven by, first of all, from Cineco's perspective, where they've established their network, and also because I know some years ago we were looking at another jurisdiction that we were, as an option, and the challenge that we had was getting, and it wasn't Cuba, it was another jurisdiction, getting the information from that jurisdiction regarding how they regulated their healthcare system, so that, going back to your question about quality and patient safety, so that we would be able to satisfy ourselves in terms of the standard of care that we be sending our patients for. So that's an exercise I think that we would need to look at. And I'm not aware if Cineco has looked at Cuba. I don't know if that's something that they're actively looking at doing. But I know that when we had Cineco under our ministry and we were looking at another jurisdiction, that was the challenge that we came up against. It was, how will you be able to, if God forbid you send the patient to this jurisdiction and something goes horribly wrong, how will you be able to tell the family that you satisfied yourself, that you weren't sending them off at their peril? So it's something that Cineco probably might, and I don't know if they are actively looking at.
Well, I mean, I think it's obvious. I know they aren't because of a recent incident that I had with a constituent member of mine. But I've been given a commitment at least for the last 5 years on almost an annual basis that they would. And certainly the simple basis for quality in statistics is international published statistics. And I can give you real life examples. I mean, in the case of this constituent, he was treated at the HSA for well over a year. No relief. He was referred to Health City and he went there several times. No relief, right? He took it upon himself to go to Cuba, right? Got immediately diagnosed that there was an infection causing the problem, was put on antibiotics and treated with lasers, and is substantial improvement. But he's having difficulty now because there used to be a kind of an understanding with Cineco patients that if you went to some place like Cuba, they would consider some kind of reimbursal, right? In fact, the reason he got treatment in Cuba was because it was almost an emergency situation. In fact, it was an emergency situation with the pain and everything else that he went to the emergency room, right? Mm-hmm. And certainly Cineco is obligated, as I understand it, under that scenario to honor the emergency treatment. But I'll deal with that as a separate issue. But the other question, I just want to, because I forgot it twice now. We were given a commitment. You all hired a Canadian health insurance company, Maru Chappelle, to conduct a feasibility study about determining a period for a specific standard health insurance contract for persons over 65. Mm-hmm. That was supposed to be completed last year. Has it been completed? What is the premium?
So, Mr. Chair, we received that report from the consultants at the end of last year, and they're coming in February to present that report to Cabinet and for us to...
You mean the report is written so that they have to come to explain it?
No, it's to allow in case there are questions, to have them there to answer it. No. The report is fairly self-explanatory in terms of the findings and what the proposals are, but the consultants are coming because we think that it would be beneficial in case there are questions from Cabinet around it. So that exercise we do have that report. It was conducted, as you said, last year by Morneau Chappelle. They got very good cooperation from the health insurance companies in terms of providing the data. They also, you may remember, did a public survey. I believe they had over 800 responses from the public to get some feedback as well regarding the information of what benefits they valued, whether they currently had insurance, whether they had a supplemental plan or the SHIC, and also another question around their tolerance for premium changes, for premium increases, and what they would be willing to tolerate for increased benefits. So we do have that, and I'm expecting, as I said, we're hoping to present it to Cabinet in February, and I think that shortly after that we'll be able to update.
Is that normal that the report would be to Cabinet rather than to the ministry, or?
The ministry has received it, and the minister, it's to inform Cabinet of it.
So that will in fact make it, is it going to be made public? the document?
Well, that's one of the things that we will be going to Cabinet for. And once Cabinet has had sight of it and understood it, then I would expect that it would be.
Because recent changes to the Freedom of Information law, if it's submitted to Cabinet, will make it not available through Freedom of Information law. Well, the minister already has it. Oh. Interesting. Okay.
Yeah.
Any other? You had another question.
Just one bigger question,
These things.
Mr. Chairman, and the street to the witness. I'm happy that she touched on the NGS 55 and HEA 2. Just to kind of give the members and the public an idea. For NGS 55, we started out with a budget for the 2018 financial year of just under $11 million. We had 2 supplementaries throughout the 2018 financial year that carried that forecast from under $11 million to over $25 million. And that NGS 55, just so the committee members are aware, that is for provision of territorial health care for indigent seamen and veterans who are referred for treatment local and overseas. On HEA2, which is essence is provision for medical care to indigent patients that goes to the HSA. That was also just under 11 million, and we had one supplementary last year that took that up to just under 16 million. So in a nutshell, Mr. Chairman, we spent roughly over 40 million last year on indigent care, both locally and overseas. And when I look at the last SEMA report, just on the health insurance industry, for 2011, the profit for the health insurance industry, only on health insurance, not for the insurance company, just on health insurance was 4 million. In 2012, it jumped to 10.8 million. In 2013, it went to 14.3 million. In 2014, it went to 14 million. In 2015, it jumped up to 51.5 million. So last year, the government spent over $40 million of taxpayers' money on indigent care. This does not include the public service, it's just indigent veterans and seamen. And in 2015, the profit just on health insurance alone, as per the Cayman Monetary Authority annual report, was 51.5 million. Again, Mr. Chairman, this is a structural problem that we have in this country with regards to health care. And the first question that we need to ask ourselves is it a right or is it a benefit? If it's a benefit, then we can continue business as usual. But the first question that needs to be answered is if it's a right. Just as though we have accepted that education is a right in this country and we have made it free and accessible within the public schools, we need to do the same with regards to health care. If it is a right, we need to make it more accessible and more affordable, and of course, with the quality that goes with it. So again, Mr. Chairman, I bring back my point, is that the issues that we are dealing with today is policy related. It has to be a bigger issue. Now, what I can say in all of this, to ask my one final question, is I met with the minister last year, and I had a very long discussion on this issue. And we also met with representatives of some of the private hospitals to see if we can put a model in place which would pretty much expand the services and also to look at providing care to the 20% of the the indigent population that drives up the cost. Now, the last feedback I got on that was that they were still waiting on some information to put together a plan. I asked the minister last year for an update on terms of where we are with that information being provided to those entities, because it is a problem that we are trying to address. And the question I have for the chief officer is the information that the private providers are waiting on to make the proposal to government, has that one been provided? And two, if not, when will it be provided to them? Because this is something that we really need to take a hold on. But spending $40 million or more than $40 million in 1 year on indigent veterans and seamen in a country and where it is a strain on the public resources, and for the health insurance and for these guys to be making this much money on health insurance in terms of profit, can't work.
Through you, Mr. Chair. The figures that the member quoted regarding the health insurance profits, that's the Health Insurance Commission has recently done an exercise to look at those figures in collaboration with the Cayman Islands Monetary Authority, and I believe that some clarification is going to be forthcoming. I think some of the way that the figures were reported was
No. The first time we put those figures out, we were given that answer, and I've since gone back and asked for an updated report, and I was basically told one wasn't coming. It is what is reported. It is what is in the public. So if SEMA needs to change it, they need to change it. So whether it is 14 million or 51 million or 20 million or 30 million, the problem is, and I don't have a problem with the health insurance companies, the insurance companies making a profit. What I do have a problem with is, well, one, the 51.5 million being reported is a problem. But for me, the bigger issue that we have to deal with here is the more than $40 million that we're spending on this care. And when you consider the forecast in terms of just the NGSS 55, the budget document I looked at had a monthly spend of less than $1 million, and it increased to over $2 million last year, which is like more than a 50% increase. You look at HEA2, again, based on the budget document, we're spending around $900,000 a month. On average, it is now up to basically over 1.3 million per month, which is between a 40 to 50% again increase. So realistically, these numbers are going up. And if in 1 year alone we had a 50% increase, this is something, it is definitely unsustainable. And we just can't keep throwing money at the problem. It has to be driven by policy and what it is that we need to do as a country. So the issue, and again, as I said before, the solution to this is outside the remit of this committee, because that is a policy issue. But for us, the main thing is that it can't just be business as usual, but rather what it is that we're looking for. Now, like as I said, to give the minister, to give Jack his jacket, the minister did hear, met with me, did hear my concerns, and like I said, we had meetings with the private sector individuals. I have since followed up with them, and they're just waiting on information to basically start looking at a solution to this problem, because it is a problem, and we're trying to find a solution. But like with anything else, we heard yesterday, the NAU have a database issues with their database to get to the root cause of some of these issues. We're hearing today, same thing as my colleague from Prospect raised, with regards to the information that we need for the proper planning. And I guess this comes back down again to information. So for us to make an informed decision, we need the information to do so. And what I'm just trying to get at is getting the information to those people based on the information that we have, and this is what was given to the public. So I can only go by what was given to us and not what someone says, well, those numbers are wrong. If they're wrong, then SEMA needs to fix them, and they need to go fix it in the public. But it is a $40 million problem, or the $40 million elephant that we're trying to get fixed, and it is that information that we're trying to get to the root of.
Thank you, Mr. Chair. Through you, just as a sort of clarification regarding the budget and the expenditure on HEA2 and NGS 55, and the government's expenditure on the indigent seafarers and veteran population has been between $2 and $4 million per month for many, many years, between the health insurance that covers the HSA care for the seafarers and veterans, HEA2, which you've referenced, which is the fee-for-service care for the indigents at the Health Services Authority, and then NGS 55, which is the non-Health Services Authority care for the indigent seafarers and veterans population. And if we were to look at the spend on those output items over the years, at the end of the financial year, we would recognize that while it has been going up, It hasn't gone up. The member mentioned we had 10 million and then we went to almost 30 in the budget. Really what it is that the numbers of people accessing the system have increased, but the government has spent those kind of figures year on year. So it's not a situation that we spent $10 million in 2017 and then it jumped to 30 in 2018. And it is a budgeting issue. It's a forecast. It's not even really a forecasting issue because we look at the numbers and we can say this is what we're going to need. I think we have been able to come and get supplementary funding when it's been required, and it has been required. And I can say sitting here today that we have 10.8 or let's call it $11 million in our budget for NGS 55 in 2019, and we know out of the starting gate that that's not going to be sufficient because of the number of people on the program and the historic spend that we have seen. So, you can expect that we will be coming for a supplementary on that. And the questions are around, and I'm sure this is something that may have come up in your discussions yesterday with the Needs Assessment Unit or the Ministry of Community Affairs. It's around access. Who's accessing these programs? What package of benefits are we prepared to cover with these programs? Do we want to, and going back to an earlier the response, we have the working age indigents and we have the seniors. Do we want to have a different plan of benefits or a different package of goods depending on the individual indigent circumstances? Is that something that we want to move towards? We have some cases of working age people who end up on the indigent list when they're very ill, and then they get the services that they need, and then they are able to go back to work and they're fine and come off that list. So those sorts of fluctuations are part of the challenges that we have with it as well. So it's a big, as you said, it's a substantial amount of money that is being spent by the government to provide this service, this social service to support this group, and definitely something that is not going to, it's certainly not going to decrease unless there's some policy changes around who's accessing, what they're accessing, where they're accessing. And those discussions need to happen. And we also need to, like I was speaking earlier, the chairman asked about the SHIC 65, the work on the SHIC 65. Given that half of this group, half of this indigent population are 60 and over, the impacts of what the policy decisions are regarding the recommendations of the actuaries from the SHIC 65 will impact 50% of this indigent population, potentially. So things are being looked at and steps are being taken to try and identify a more sustainable way to deal with this problem. But I think that particularly with the indigent group, some of the discussion, some of the decisions are going to be wrapped up in the work that the Community Affairs Ministry is doing around the support that they're providing.
Please, I just need clarification. Oh.
Sorry, Madam Chief Officer, just in terms of the information that the private providers need to make a presentation to government with regards to what it is that they can do, when will that information be provided to them? Is pretty much what it is that we're looking for, because like I said, to give credit where credit is due, this is something that the minister is working on. I'm aware of it because I was present while at a couple of those meetings, and the feedback I got last is that they were waiting on information from the ministry for them to make make a presentation to cabinet in terms of what they can do in terms of helping the government to reduce the costs. So I understand that information needs to come from the ministry, and that is what it is that we want. So, I mean, I'd asked the minister, he couldn't provide the answer. He said he would have checked back and get back, but since you're here, we're just trying to find out when they will get the information.
So one thing that, through you, Mr. Chair, the ministry is in discussions with issuing an RFI, a request for information, under the provisions of the procurement law. in order to get a better idea of what, as Minister Tibbetts, you say, what obtains in the market in terms of availability and cost and the best available prices. So under the procurement law, the process is outlined to start to get that kind of information in order to be able to move forward with looking at what other options might be. And as I was saying earlier, 50% of the indigent population are over 60. So in terms of what information we're going to be looking for, some of that will hinge on the decisions that are made regarding how to deal with the senior citizen. So it's one thing to go out and ask the market for some information regarding costs for 500 people, a group of 500 people age 0 to 60, versus asking for information on a group of 1,000 people that includes 0 to the end. So it is something that we're going to be pursuing and going through the procurement law processes to get that information from the market and inform, as you said, the decision that Cabinet's going to make.
Sorry, but before they can price the 500 or the 1,000, they would need to know what their current ailments are, because no one can go into it blindly. And it is that list of current ailments is what they are trying to basically get to determine what it would be. So the information still would have to be provided, because no one is going to show up and says, I'm going to charge you $10 per person. No, if you're spending $40 million and you even have 1,000 people, that drives up that cost. That's still an average of $40,000 per person. And the whole idea behind insurance is to spread risk. So no one is going to, if there's a $40 million spent already on that 1,000, and we want to slice it and dice it, it is still, the pie is still 40 million. And the average would be 40,000 per person. And if they were to take that cost and share it up amongst themselves, the premiums are going to be what? Over $3,000 or $3,333.33, whatever, per month. So, I mean, and so the whole idea is to take the pool that we have and expand it, because it can't be a situation where people are working for 40 years. I remember during the budget discussion where the CEO of Cineco at the time said the true cost in terms of for the government of in terms of premium, for a person over 60 or 65 it was around $1,300 between $1,300 to $1,500 a month. And now we have the pension law for the private sector that limits them to $1,080 a month in terms of drawing. So there's already a disconnect between what a person needs today just to pay a health insurance premium to get a decent premium versus what they can even collect. Then you're talking about the other living expenses that a person would need. So there's already out the starting block. And what we have is a problem within the private sector that is being dumped on the government, and in particular your ministry. Thus the reason I said yesterday that the problem that we have is structural, and it is private sector people or former private sector people that is driving up this cost. And it can't be a situation where businesses in this country are making millions a year in profits, and the taxpayers at the end of people working lives is stuck to take care of the people, when for 40 years they would have been insured in private sector. They would have made them, whether it be 40 million or 50 million in profit. And now, once they're done and discarded, they become the government problem. This is completely unsustainable. And what it is that we're looking for, and this is why I went with the minister and we had this discussion, is to say to the hospitals and the local providers, here is the issues that we have. Come and you guys work together and find a price for it. And this is something that they've agreed to give them the credit, they've agreed to it. But the problem that we have had now where we're stuck is that they say we can't give you a price because we can't get information, which the minister committed to provide them the information so at least they can all work together, because they recognize that this is a problem. And at the same time, give us an opportunity to start even enhancing our own local care, not just primary and secondary, but some tertiary care. This was some of the discussion that we even had with Shetty, that they were willing to invest in other areas. I mean, cancer is still a big problem for us. So this is not a situation that is political. This is a national problem, and that's the reason why we have agreed to work with the government in terms of finding the solution. But we need the information in which to get the solution now. I know the insurance lobby is strong because I've already gotten some WhatsApp messages already from some people based on what I sent out New Year's, and that's fine. But it can't be $40 million a year that we spent last year on indigent veterans and seamen becoming the norm, which as soon as someone retire, and they're going to retire, they're going to become the government and the taxpayers' problem, and of course, more work for you. So the problem in all of that to say it's bigger than the ministry, it's bigger than the public service, it is something that the whole country needs to deal with and the whole country needs to accept. But we need the information, and thus I come back to when will that information be collated and when will it be provided to those guys so at least they can say, well, guys, here's what we can do. And if at that point, if it is too much, because I'm sure the government will sit back, and so far they've been transparent in working with the opposition in that regard to say, guys, you think this is something feasible or do we need to be looking at something else? But we need information.
And through you, Mr. Chair, and that was, I should have clarified that when I said that we would put out an RFI. Part of the RFI process is to put the information, to provide the information, because you're absolutely right, they can't price what they don't know what they're being asked to price. So under the procurement law, we would put out the RFI with the information and to get the input from the market to say, for this book of business, for these services, you know, what kind of costs would you be prepared to, or would you be looking at in terms of your provision of services? So you're absolutely correct. The RFI would have that information as the basis of it. The member touched on so many different areas. It's just, but it's a real challenge. There's absolutely no question that it's a question of sustainability. There's policy decisions that need to be made behind, you know, as I said earlier, the access, the who's accessing, the what are they accessing, how are they accessing. Not just healthcare, but all of the support services that we provide. And, you know, and the whole issue of the cost of health insurance for someone on a fixed income post-retirement, I mean, that's a really big problem. And one of the reasons why the work was done with the actuaries to look at this SHIC 65 and see whether or not that might, you know, what the approach might be to try and address it. So yeah, I mean, it's significant, and it's something that, you know, we need to work and collaborate to address.
Going back to the RFI in terms of the date, what timeline are we looking for the RFI to basically be going out to the providers?
Through you, Mr. Chair, that will depend on the timing of presentation to Cabinet and decisions on the SHIC 65, as well as some other work that we're starting at the ministry.
Something is wrong here. The government policy used to be that we were going to health insurance so as to spread the healthcare cost across the total population. Is that being changed now to where we are going to have a single provider? People are now going, because what we've already done, you told us earlier that the Health Insurance Commission is spending time trying to dumb down the profit reports on the health insurance companies rather than saying to the health insurance companies, because you made all this profit, we need to expand your coverage. And now we're going to where we're going to invite people to provide, we've already fragmented the risk of the insurance by government having 9 different votes that they supplement the insurance with, right? We talked about the pharmacy not having adequate coverage for the pharmacists, and the government solution to that was to provide cash as opposed to going to the health insurance companies who had made $51 million before and says, based on these facts, you have to up your coverage on this plan. And we're now considering a policy where we're going out for a PFI to go to single provider, a single provider bid to provide health care, as opposed to something in my mind don't match up.
Mr. Chair, just to clarify the work that I referred to the Health Insurance Commission doing, it's that the Health Insurance Commission is getting or reviewing the information, the returns from the health insurance providers to see where the numbers actually land. It's not an effort to dumb down what's being reported. It's just to try and verify what the actual situation is, and they're working with internal audit now to finalize that. The RFI that the member is talking about is to get some information regarding what opportunities are out in the market to spend or to get more cost-effective care for this group, the indigent
More
population.
cost-effective care based on what? Based on what the insurance companies are paying or what government is paying through its supplementary funding of the insurance industry?
When you refer to what government's paying for supplementary funding,
The 60 million that we have in 8 or 9 different votes that we pay for through Seneco and other agencies. And
so Mr. Chair, the 40 million we were speaking about earlier was around the cost of care for the indigent seafarers and veterans, who are the seafarers and veterans have an insurance plan through the Ministry of Finance for their HSA care, where it's funded on a premium basis. The HSA care and the non-HSA care for the indigents, as well as the non-HSA care for the seafarers and veterans, is funded on a fee-for-service basis and administered through Seneco with an administrative services only fee.
I know all of that,
Okay.
but the premium that the Minister of Finance is paying to Seneco is based on a price for only the seafarers and indigents, or is it priced on the global coverage which is what insurance is about? Health to civil servants, the civil servants' families, so as to keep the premium down. Because any insurance company, whether government owned or otherwise, that you ask to give you a price on people who are sick and you don't involve anybody whose health in it, it's going to be high.
It spreads the risk, yeah. Mr. Chair, I'm not sure if the Ministry of Finance, because I'm no longer on the board for Seneco, so I don't know.
Mr. Chairman, thank you, sir. I'll just say briefly that the premiums which central government now pays to Seneco for civil servants, for seamen veterans, those premiums are now currently being based on the age of the particular individual, the age of the civil servant, the age of the relevant person being paid. Off mic, the public wouldn't hear you, but you were asking, well, why? I think it's simply on the basis that the risk of incurrence of medical services and the need for it generally will increase with age. And that would be the rationale.
That defeats the very purpose of health insurance, where the younger people who are healthy pay a little more to help lower the price of the older people who are getting sick. Because all of us can get old, and in our first 20, 25 years of working in government, we're basically healthy people. You only got to look at the indices that is reported in the health reports, and it'll show that we have a very healthy population, except when you get up to the lifestyle diseases that take effect 60, 65 and up. And as long as the government continues to separate those, of course, it's to the insurance industry advantage for you to separate them, because they're going to get more premium. And therefore, they can make more profit. In this case, it's not a profit thing, but Seneco is getting more premium than it should, because what the civil service should be doing is going to their own actuaries and getting an actuarial calculation as the cost of health insurance that they should be paying for that total demographic. And I've been arguing this with government now for 9 years. Nobody's listening to me.
Mr. Chairman, sorry.
But the reason the health insurance companies are making $51 million a year profit is because they're not insuring anybody who's sick over 60. And government is following into the same trap by paying a lower premium for people age 18 to 20 or 35 or whatever, and then getting hit with a higher premium down the road. That's not insurance. That's a cost for care.
Mr. Chairman, I'm just looking back at my notes, going back to the SEMA report that came out. Back then in 2015, per the ESO numbers, there was 39,138 people employed, of which civil service numbers at the time was 3,588, which left between the private companies and the SAGCs 35,550 people within the workforce that would fall within that pool for the 51 million. So to make $51 million profit on 35,000, but the part that scares me the most, and that still bothers me, is considering that the 2015 numbers had to be submitted to SEMA in the first quarter of 2016 as per the law. We're now in the first quarter of 2019, which is 3 years since those numbers would have been submitted. And the issue behind us raising the profit from those reports wasn't to begrudge the health insurance companies from making whatever profit, because we're happy when businesses make profit. What caused us to bring SEMA here and also the Health Insurance Commission was simply this. Having a group of companies move from 40 million profit 1 year to 51.5 million profit the next year, being reported, whether the numbers are right or wrong, it should have created a red flag within the policymakers to say, wait a minute, what just happened? And the purpose behind that Public Accounts Committee meeting was to find out from both SEMA and the Health Insurance Commission, since these numbers were reported to you, whether they were right or wrong, they were reported to you. What have you done? What have you gone back from a policy standpoint? What have you said to the minister? What have you said to the cabinet? Guys, we have a situation here. The bottom line is profit moved from 40 million to 51.5 million, and nobody said anything. And that really was the genesis. And the only response we have heard now is the profit has moved from 14 million to 51.5 million year on year. But the 51.5 million number is wrong, but no one can tell us what the number is. The issue isn't that it moved from 14, the issue is not that they made 51.5 million. The issue is that it jumped up that large and nobody said anything, nobody did anything, and the public is paying people to look out for their best interests. And I don't want to hear the number is wrong 3 years after it's been reported. What I want to hear is what the government is now doing to make sure that they're monitoring this, to make sure people are getting value for money. But 35,000 people being made 51.5 million off of them, just on health insurance alone, it is unsustainable. And that is what we're looking for. Listen, this is a big problem. I recognize that. There is no magic bullet. I recognize that. But at a minimum, what we need to make sure is that the information we're given, whether it's right or wrong, is what we use to make our decisions. And that is what we need to make sure. And this is what the politicians and the representatives depend on the technocrats within the civil service to provide us, that they give us numbers and that they're right, and then we make our decisions based off the numbers that are given. And if a number is wrong, come back and say the numbers are wrong. This is the correct number. That's what we need. But SEMA has not changed their reports. I've checked. It's still the same number that is out there, and that is what we need to understand what is happening with health insurance. The Auditor General has gone through and have done a very good report, 2 reports to be exact, on healthcare in the Cayman Islands. And what we're trying to find now is a solution to it. So if the RFI is the way to go, I've been told by the minister that they're waiting to get information out, and now from the civil servants, and now you're the chief officer is telling me that you're waiting on the minister to, I mean, there is a circle here now where it is clear that we just don't have the information on which to make the decisions. And if that is the case, then why are we here?
If not, Ms. Ahorn, we thank you for coming and giving the Public Accounts Commission evidence. Thank you very much. Have a good day. The committee
Thank you,
the public hearings will be adjourned until 9 a.m. 30th of January, when we'll be dealing with fighting corruption in the Cayman Islands, report by the Auditor General, November 2018. I just want a little bit of housekeeping. I just want to remind members that we have a debriefing with Mr. King and the LA staff at 1 o'clock after lunch. Well, I guess it'll be 1:30 now. So thank you all very much. Have a good day.